everyone, we are back with another episode of 25 Days to Question Your Induction with Improving Birth Abbotsford. I'm Carly. I do the stats for Improving Birth Abbotsford, taking the Perinatal Services BC data. I also answer a lot of the messages that come to us. Usually if it's about VBAC, I then direct you to Christine or Wendy, depending on your situation. Sometimes you get to talk to both of them. But initially, you usually get me. Sometimes you'll get Christine if she's quicker on the draw. I cover all of Fraser Valley and BC so far. I'm trying to get bigger, but it's going to take a long time. It's going to take a lot of us. All of us who care about birth need to come together in Canada and get together on this and keep pushing the message forward. And it really just takes sharing these videos to do that. You don't have to be a super big advocate like me. You don't have to sit there with the stats all day. I know that's not always fun for a lot of people. It is for me because I'm a little bit of a birth nerd. But if you just want to pass on information, that by itself is a lot of help because you can pass on these videos. We have a YouTube channel now. If you're watching from YouTube, I encourage you to subscribe or share. I'm not trying to get money off of this or anything. That's not the reason why I'm doing this. I'm doing this for you guys. I'm doing this to basically change the face of birth and to give women the power back for their births and choose what they want. So we've been doing the 25 Days to Question Your Induction. And I've been reading from this book, Why Induction Matters by Rachel Reed. She does the blog Midwife Thinking. I get no payment for the endorsement of this book, but I do encourage you guys to pick it up because it is a fantastic book. Now, I've done this, the first video in our series is on the stats for induction and C-section in BC, Fraser Health, and Abbotsford. So if you're not from that area and you don't really care, you can skip that video. If you're a little bit of a stats nut, you can watch it, of course, but if you want to just come back to it later and get to the good stuff, you can do that. So the next videos we have are the informed consent videos and decision-making framework and how to make decisions, and it will give you the tools you need to be able to ask questions and take charge of your own care. And I say care, I don't say maternity care, I say care, because a lot of the time when we go into the medical system, we just do what the doctor says, but we don't take in all the information that we need to take in. And they say, do you have any questions? And you draw a blank because you don't know how to ask the questions. So this is more about taking charge of your own health care and maybe giving a little bit less pressure onto our already pressured healthcare system. If you've gone into the waiting rooms in a doctor's office or been in the emergency room with a kid that stuck a bead up their nose, for example, and seen the wait times and how many people are waiting to see a doctor that may have severe problems that are worse than what you've brought your child in for, and you feel guilt because you really don't have a choice because the walk-in clinics are closed and you have to take your kid in to emerge, but you see how it is, then you can kind of understand why we want to reduce the number of unnecessary interventions, because even though we're not paying for them, the healthcare system is still paying for them. So that money could be redirected to hiring more staff. It could be redirected to buying in more beds, getting more rooms built, getting another facility built, getting healthcare for the geriatric community that needs it, getting healthcare for the people who have chronic health conditions, getting healthcare resources for people who have mental conditions, psychiatric issues. All sorts of things need the money that is being directed to the unnecessary C-sections and the unnecessary inductions that are resulting in unnecessary C-sections. It's like $4,000 for just an uncomplicated C-section. And our rates are higher than the rest of Canada In BC, our rate of C-section is higher than the rest of Canada. It's higher than the national average, guys. It's 1 in 3 women in BC versus 1 in 4 women in Canada are having C-sections. And it needs to change. And one of the things that I've seen through the SOGC, through their induction, they actually said that the rate of C-section triples for a first-time mother being induced with labor not basically being ready to be started. So with a very, very low Bishop score, you have almost a 50% chance of having a C-section or higher, depending on if baby was ready or not. It's not good. Induction was designed for complications. It was not designed for what it's being done for now, which is basically profit, convenience, and liability, and just the cultural perception that it has to be done. And we're skewing the national average for average gestation because a lot of women aren't going past 42 weeks because they're just induced at 41 weeks and that's it. Or it's 10 days past their due date. So you get induced. You're 42 weeks. You have to be induced. Done. And the home birth community, the women that are choosing to reject that notion that they have to be induced and they stay home, they're a small fringe and they're not being studied. Their populations are not being studied. They're being criticized, but they're not being studied. And we should really be questioning, well, they're having healthy babies at home. And they're 43 weeks and 44 weeks. And what's going on here? And why are all these women that are in the hospital being induced? So, after the informed consent, we have our complications. And our complications videos cover everything that induction was actually made for. And then after those videos, we have our variation series. And those are the ones that are more commonly for induction, where a lot of people just don't question it. It's like, well, that's just what you do. You go over your due date, you get induced. You're of advanced maternal age, you get induced. You're a VBAC and you don't go into labor by 40 weeks, you're induced or have a repeat C-section, or you have a big baby, so you got to induce. And now we're going to be talking about multiple pregnancy and the preterm, or not preterm, but pre-labor rupture of membranes. So this is when baby's at term. So multiple pregnancy is actually a very interesting one because we don't have a lot of information on it. Most women, they're told that they just need to have a C-section by a certain point. And very few women will actually attempt to have a vaginal birth with twins or any multiple pregnancy. To find those, you can go on to Birth Without Fear, and you can find those small fringe stories. And we do have a mom in the Fraser Valley who we talked to at the baby fair way back in 2015. And she had a vaginal birth with twins because she absolutely did not want a C-section. And I do have her number. So if there is a mom out there who wants to attempt a vaginal birth with twins, I can pass that number on to you. I'm not going to put it in here. It's confidential. But if you message us on Improving Birth Abbotsford, I can give you the information that you need to talk to her. So that's one of the things. I encourage moms who have had variations of pregnancy, who did not induce, who had vaginal births, who had home births, with breech babies, who've had home births with twins, who've had home births with triplets. If you've had one of those variation type pregnancies and variation type births and you went against what the standard of for prenatal care and birth, what our medical system basically says you have to do, I encourage you to contact us. We would love to have you on our team as basically to consult whenever we have another mom that comes to us and says, hey, I've got this problem. and I've got this variation, and the problem is that nobody is taking me as a care provider, or they're saying I have to do this. What are my options? And I would like to be able to connect them with you. Because if I can connect them with somebody who's actually already done it, that's going to have a lot more of an impact on them than if I just keep giving them numbers and stats. Numbers and stats are great, but if you don't have the actual reference of somebody who's done it before and knows the struggle that you're going through and knows the little pitfalls that you may fall into, it's not going to do as much good. So we're going to get into multiple pregnancy. So multiple pregnancy refers to more than one baby growing in the uterus. Multiple pregnancies are usually twins, but it can be triplets, quadruplets, or more. The way that they do IVF now, it's less likely that you're going to have multiples with IVF treatment, just by the way that they do it now. But it's still a higher instance. So with IVF treatments, you're basically introducing more than one embryo or more into the uterus, and that can lead to more multiple pregnancies. But the rate in our own community is actually relatively low. And it's mostly older moms who are doing it. And then again, we also have the skewed number of how many moms that are older are just automatically induced and have C-sections. So you really have to look at all the data and then kind of intertwine it when you look at these numbers. But there's also a different type of multiple pregnancies. So non-identical twins, also known as the fraternal twins. It's called dizygotic. They're the most common type of multiple pregnancy, and they result from separate eggs fertilized by separate sperm. Non-identical babies have a different genetic makeup, and they can be different sexes. They also have their own placentas, and they're enclosed in their own amniotic sac or membranes in the uterus. Now, identical babies, monozygotic, happen when a single fertilized egg splits, creating more than one baby. Identical babies share the same genetic makeup because it's from the same egg, and they will be the same sex. Depending on when the fertilized egg splits, some identical babies share a placenta and the outside layer of the sac of membranes, which they call the chorion. However, they are usually enclosed in their own layer, the inner layer of the membrane sac, which is called the amnion, and therefore remain separated from each other by this thin layer of the membrane. So women who are pregnant with more than one baby have an increased chance of developing complications of pregnancy. This is why they usually talk about variations that can lead to complications. So, such as preeclampsia and gestational diabetes. We have that in our complications series, so if you want to go back, that's the first video in our complications series for hypertension. It's on hypertension, preeclampsia, and gestational diabetes. So babies who are multiples are also more likely to be growth restricted and or be born prematurely. Our IUGR video is the third video in our complications series. It's IUGR and small for gestational age. Around 60% of women with twins and 75% of women with triplets go into spontaneous labor before 37 weeks. So then you have the chance of preterm pre-labor rupture of membranes, which can happen. That video is our last video in our complications series. It does have a trigger warning because it also contains a stillbirth information in it. But that's another thing because, I mean, before 37 weeks, you're not term. So there's complications that are going to be associated with that. But if you go past 37 weeks with twins, then that's not even a risk factor for you. So it's only if you're going to go into labor before 37 weeks that you really have to worry about that complication. So most of the research into multiple pregnancies focuses on twins rather than triplets or more because twins are more common. That makes sense. The risk of perinatal death, combined stillbirth and neonatal death in twin pregnancies increases with gestational age after 37 weeks. So, for example, the risk of perinatal death at 37 weeks is 0.4% compared to 0.5% at 38 weeks. So yeah, the risk does double, but it's 0.4% to 0.5%. So these general statistics have been used as evidence by the NICE guidelines to recommend planned birth by induction or cesarean for multiple pregnancies. The suggested timing of the planned birth depends on the type of multiple pregnancy. Birth is recommended from 37 weeks onwards for twins who have their own individual sac of membranes, which is dichorionic, and from 36 weeks onwards if they share both the inner and outer layer of the membrane sac, monochorionic. So that would probably be identical twins. For triplets, birth is recommended from 35 weeks. The decision about the type of birth, induction or cesarean, will depend on the position of the babies and other individual factors. So, here's the part that's really interesting though. Despite the NICE guidelines, there is little research examining the outcomes of planned early birth for multiple pregnancies. A Cochrane review examined 2 studies that compared planned birth at 37 weeks for twin pregnancies with waiting for spontaneous labor. And there was no difference in the rates of complications, including perinatal death, between the 2 groups. The WHO, the World Health Organization guidelines, state that there is insufficient evidence to make any recommendations about induction for uncomplicated twin pregnancies. So if there's no complications, there's actually insufficient evidence to induce your labor. And when they're making those decisions and those recommendations, they're again combining all the information for moms that have had preeclampsia, moms that have gestational diabetes, moms that have growth restrictions, moms that have pre-labor, preterm rupture of membranes with twins, and they're combining all that to make that number for the stillbirth rate. So there's a real problem with that. And the World Health Organization has actually called it out and said that it's insufficient evidence. Now, here's the fun one that a lot of moms, first-time moms especially, you'll see these questions in the forums. When did your water break? Where were you? Now, in a physiological birth that hasn't been messed with, your water may not break until the baby is ready to crown. It may not even break at crowning. You may even be able to birth your baby within the amniotic sac, and that's called encall, and it used to be considered a mermaid birth, and it was good luck. Before medicalization of birth happened, this was a normal thing for the membranes to remain intact. And a lot of women now, they have their waters broken in the hospital. Before they've reached the end of their labor, they'll say, oh, well, they had to break my water because it didn't break on its own when labor started. And that's not how physiological birth works. Now, membrane stripping, membrane sweeping, we posted a little tiny video that was shared through the Women's Oasis of Maternal Wellness and Birth. WOMB, they're called. I'm sure you've seen a lot of their posts that we basically share them. They showed a video on membrane stripping and what it actually looks like. And they're basically going around the cervix and pushing the bag of waters to get away from the cervix. And it doesn't look very comfortable. And it's not very comfortable. I mean, some women don't mind it. They don't feel it. But I am one of those women that's like, I'm not doing this. But membrane stripping can lead to weakening of the membranes and can lead to pre-labor rupture of membranes. So that's something you really want to think about before you even allow a care provider to do a vaginal exam or a membrane sweep. And I have seen stories and heard stories and had women say, well, you know, I had my cervix checked and they stripped my membranes and then told me after. And every time I hear that, I get angry. And why do I get angry? Because that is illegal. They are not supposed to do that. That is not part of a vaginal exam. That is lack of informed consent right there. If somebody does that to you, that is assault. call it what it is. It is assault. They are doing a procedure to you that you have no idea that they were going to do, and you may not have consented to if you had known the risks of it. So, pre-labor rupture of membranes. There's a way that you can reduce the risk besides avoiding the membrane sweep. You can also take, I think it was 500 IU of, or 500 milligrams of the vitamin C, and then 500 milligrams or IU of the, what was it that she had me take? Vitamin E, and then do another 500 of the vitamin C. I'll have to get the exact thing for you, but it worked. I mean, my waters don't break until right before crowning. I wanted to have a call birth, which is why I really tried to keep up the regimen. But from 37 weeks onwards, if you take lots and lots of vitamin C and alternate it with vitamin E in the afternoon, don't take vitamin C and vitamin E together. So you have vitamin C in the morning, vitamin E in the afternoon, and vitamin C in the evening, and you keep that regimen up, you can get really, really strong membranes, and they're less likely to rupture. Unless, of course, somebody just breaks your water when they're doing a membrane sweep, which is why I say to avoid the vaginal exams. They're not necessary. Your cervix is not a crystal ball. You don't need it done. So, pre-labor rupture of membranes after 37 weeks. The amniotic sac plays an important role in the physiology of labor. We will get into that with the physiological birth chapter, which is fascinating. Without intervention, the amniotic membranes usually stay intact until close to the end of labor. However, 10% of women will experience the waters breaking as the first sign of labor, before the contractions start. Most of these women, 79%, will go into labor within 12 hours of their waters breaking. And 95% will be in spontaneous labor within 24 hours. So the NICE guidelines, we're going back to that, recommend offering induction to women who are still not in labor 24 hours after their waters have broken. So induction for pre-labor rupture of membranes is often referred to as augmentation of labor. So it may be that they have changed the way that they have the stats, but I think that they lumped induction in with just as with the pre-labor rupture of membranes because it says indicator for induction. I could be wrong, but a lot of the times with induction you have labor augmentation. So when you look at the perinatal stats, if you have a perinatal stats for your province, I would be really interested in having that link to me. So send it to Improving Birth Abbotsford through the messages, and I will be able to find that stuff, and I can work on your stats too if you don't want to do all the numbers and stuff yourself. I'm fascinated by this, guys. So it's a fun thing for me. So now, the main reason induction is offered after pre-labor rupture membrane is to reduce the chance of infection for mother and baby. That's because if your membranes are broken, then anything introduced into the vagina is going to go up into the uterus. A Cochrane review compared induction of pre-labor rupture of membranes with waiting for spontaneous labor. Although the review concluded that the rate of infection may be reduced for babies who are induced, it also raises concerns about the low quality of research. The only finding backed by moderate quality research was that there was no difference in the rate of infant deaths between the induction and the waiting groups. The review reported a slight increase, less than 2% increase, in definite and possible infections for babies when women waited for spontaneous labor. However, once the possible infection results were removed, the difference was no longer significant. The possible infection rate was based on the care provider's observations of symptoms rather than on the clinical diagnosis of infection. So, for example, if the mother had a raised temperature in labor, her baby may have been assumed to have a possible infection. However, other factors such as dehydration And epidural analgesia, the epidural, also increased temperature in mother and baby during labor. There is also no difference in the APGAR scores of babies in the waiting group, suggesting that babies were well when they were born. Infected babies are more likely to have a low APGAR score and require resuscitation at birth. Babies were more likely to be admitted to special care after spontaneous labor, but their outcomes were not different in comparison to the induced groups of babies. This finding most likely reflects hospital policies that often require routine admission to special care for observation after prolonged rupture of membranes. The review also found a slight increase, 1%, in the chance of an infection in the uterus for mothers who waited for labor. The conclusion of the review warns that in order to make a good comparison of outcomes, evidence about long-term effects of induction or waiting on children is needed. So, some care providers recommend routine antibiotics for women who have pre-labor rupture of membranes, especially if the baby is not born within a particular time frame. So again, we're back to being on the clock. However, a Cochrane review concluded that antibiotics should not be given routinely to women with ruptured membranes unless there's a sign of infection. So if they're saying, okay, well, your membranes have ruptured, we need to give you antibiotics, you can say, well, do I have any signs of infection? No, I don't want them right now, but if I get a sign of infection, then I'll take them. And you have that right to say that. And they have the obligation to honor that. So it also says, the review found no strong evidence of any benefits of routine antibiotics. It also stated that not enough is known about the side effects of antibiotics for mothers and babies. Routine antibiotics should also be avoided for the baby after birth unless there are signs of infection. In keeping with the Cochrane review, NICE guidelines recommended that if there are no signs of infection, antibiotics should not be given to either woman or the baby, even if the membranes have been ruptured for over 24 hours. Signs of infection for the mother include fever, smelly vaginal discharge, and painful uterus. So if you don't have any of that, you don't have to worry. And if you have an epidural, the fever may be because of the epidural. That is one of the possibilities with an epidural, is you can get the fever. So also, let's see here. Signs of infection for the baby include fever or low temperature, noisy breathing, pale skin color, and excessive sleepiness. Women can reduce their own chance of infection after rupture of membranes by avoiding putting anything into their vagina. And this includes avoiding vaginal examinations, because the more vaginal examinations a woman has, the greater the chance of getting an infection. So after birth, the skin-to-skin contact between mother and baby allows the baby to be colonized with protective bacteria, reducing the chance of infection. So basically, if you have pre-labor rupture of membranes, don't allow cervical checks, because that can increase your chance of having an infection and then needing to have an induction. Stay home. Stay home until labor is done. Don't put anything into your vagina. Don't check yourself. Dilation doesn't even predict labor, because I was dilated to 6 centimeters in early labor with my daughter, and then my cervix closed back up because I was stressed and I was tired and I was hungry and I'd been laboring for 24 hours and I needed to rest. So I did what my body told me and I rested. Now, if I'd been in the hospital, the policy would have been, because I was already 6 centimeters and now labor had stalled, they would break my water, try to induce me, C-section. None of that happened because I was home. I was informed. I knew that my membranes were intact. I didn't have any chance of infection. I wasn't having any more vaginal exams. I'd already made up my mind after that last one. I'm not doing this anymore. And I also knew that my daughter's, the first thing I asked was, well, how's her heart rate right now? And she said, it's fine. So because I knew that her heart rate was fine, she wasn't in distress, so I could basically let things take as long as they were going to take. I thought, okay, fine, I'm going to say this is prodromal labor, and I'm going to have my file closed up, and I'm just going to do my thing, and I'm not going to think about labor anymore. I'm just going to go to bed. I'm going to follow my body. I'm just going to go to bed. So that's what I did. And the only reason I had called my midwife so early in labor in the first place was because I had an appointment that day to be seen, and I didn't want to get in the car, so I figured it would be better to just have her come to the house later. So that was more the circumstances of me not wanting to get in the car in early labor and have to deal with that. So yeah, that was why I did it that way. Otherwise, I would have just kept on as I was going. But in the bright side, I got to sit in the pool, and that was nice. But if your waters are intact, there is no reason why you need to speed up anything. Just let your body go at its pace. So we're done the variations now, and we'll be going into spontaneous labor in the future. We also have about the medical ripening of the cervix and breaking the waters, which is part of what the induction process is. Then the medical inducing of the contractions with the Pitocin, which people keep calling oxytocin, and I refuse to use that term because oxytocin is what your body makes. It's not what is in the IV drip. It doesn't even function the same way as what your body makes. And then there's alternative methods of induction and creating a medical birth plan. So I encourage you guys, even though we're done the variations and the complications and the informed consent, I encourage you to keep following these videos. It's not going to be called 25 days to question your induction anymore. It's just going to be individual videos on what these things are, because the questioning of the induction is really about variations in what the evidence says, and the complications and what that evidence says and how to make decisions. That's all about questioning it. Now we're going to go into what induction is and isn't, and what spontaneous labor is, and how our bodies basically work. So it'll be different, but I encourage you to keep watching these videos because this channel is going to help so many people. Share them, put them on your parent forums. I know you're in a few mom groups. Most women my age and younger are in mom groups now on Facebook and in other little groups and things on the internet. We have a large information network, and if you're in Canada, I encourage you to share this information because I talk a lot about the SOGC. And if you're in other parts of the world, I encourage you to also share this information because this book came from the UK. And it's got the same stuff from the World Health Organization. And our bodies are amazing, and we don't need to induce just because we have variation. We don't always have to induce because of a complication. It depends on the severity of that complication. So with gestational diabetes, it depends on if your numbers are controlled or not. Preeclampsia, that's a big one. That's a severe complication. Hypertension is not a severe complication. It may just be normal for your body. That's why you need to ask questions in your care, because they're going by these studies and what their guidelines tell them to say. But you are an individual, and only you can make the right decision for you. Nobody else can decide this stuff for you. They can make their best recommendations, but it's still a generalization based on everything else that they've seen from other women. And you may be completely different from other people. We all have different physiologies. Just because we all look the same as humans does not mean that we all have the right same microbiomes. It doesn't mean that we have the same genetic factors. We have a lot of different aspects of our lifestyles that can also factor into how our bodies work. So again, you really want to educate yourself, and I'm going to continue to do these videos on different types of pregnancy variations and different interventions, and I'll do the stats too. So if you're from the BC area, then I encourage you to watch the stats videos. If you really don't want to have to sit and read the reports, I'll be doing videos on the stats. So, yeah, my phone's telling me it's almost dead, so I've got to go. I will see you next time, guys. Bye.